Today we are going to have a short talk by Dr. Kumud Mehta, a consultant pediatric nephrologist. She's the author of several books on pediatric nephrology and has written in several journals and international papers. And she's going to tell us something more about nephrotic syndrome in children and her experience along with it. So I'm going to ask you the first question that all pediatricians really want to know is, can you tell us your experience on nephrotic syndrome?
I have been in this field of pediatric nephrology for almost about 30 years, and I found that this is a commonest kidney disease and which occurs between the age of 2 and 5 years. If you ask me the incidence all over the world, it must be the same, 1 in 100,000 children. So it's rare compared to the other diseases of other systems. But the best part of nephrotic syndrome is, though it looks very, abnormal faces and the child doesn't look that sick, but the parents are initially more worried about the face of a child, because it is one of the diseases where there is a lot of swelling all over the body, which is of great concern to them. But the next thing that happens is, you can diagnose it very easily. That is why probably, though the child looks very abnormal, the urine test, a simple test, it can clinch the diagnosis, unlike you don't need very highly sophisticated, sort of a studies or imaging or ultrasonography or anything. And once the diagnosis is made, the treatment is quite straightforward and simple. It is steroids, and steroids. That is oral prednisolone. There is no other, in the last at least 30 years, new drug which has replaced steroid. The response to the steroids in a child with nephrotic syndrome is excellent, to the tune of almost 90 to 93% of the children would respond. But a little, I think, unhappy situation arises, because those steroids within a matter of 2 or 3 weeks abate all these symptoms of nephrotic syndrome. This is a disease which keeps on coming again and again and again. 70% of them would have what we call relapses, means again there is a proteinuria in the urine, because the main key issue in nephrotic syndrome, we don't know the cause. But one thing is certain, what happens is the leakage of the proteins in the urine. Normally, the kidney is an organ which causes balance or a homeostasis. That is, what is needed by our body, the kidney retains. And what is not required by our body, it eliminates. But somehow or the other, something must be going wrong, which we have not been able to, fathom yet. But kidney allows the leakage of the protein, which is a very essential, sort of element for our body. Now, those steroids control it, there is no cure for it. It's over a period of time, as the child matures, you find that this state of excessive leakage of protein in the urine, which consequently causes reduction of the serum proteins in the blood and all the other features of nephrotic syndrome, they abate. Probably the kidney matures. So it is amazing for me to say that though I am in the field for last 30 years, nothing really dramatically new has happened in the field of nephrotic syndrome. Though over a period of time, if you follow these patients, because few of my patients I have followed for 20 years also, most of them come out of this situation, and as adults they are quite normal. So it's a disease which is a very satisfying disease to treat in 90%. 10%, I must say, do not do so well. And then there are newer drugs, and there are more toxic drugs which are available. But on an average, we always make this statement to everybody, whether they are parents or the doctors, that the steroid resistance is the main feature because of which few of them go into end-stage renal disease. Have I told you everything about it, or do you want to ask any more questions? Because I had a very long...
there are lots of questions.
Yeah.
So, yes, it's quite clear about nephrotic syndrome. But we always wondered how this ISKDC regimen came into the place where we give 4 weeks of daily steroids and 4 weeks of alternate day steroids. Was there some scientific basis behind this? And does it really still stand today that we need to go according to the ISKDC regimen?
I think ISKDC was a multi-centric trial. There were more than 500 children which were, sort of inducted in this study, and they were from 7 different countries all over the world. It was there was a core group, one from France, that is Dr. Rini Habib, then one person from United Kingdom, and the main place was in Albert Einstein School of Medicine in USA, New York. Dr. Greifer and Dr. Edelman and Henry Barnett, who is considered to be father of pediatric nephrology. And I had an opportunity to just go and see them. I wasn't involved in any of these studies. So what used to happen, because they had a vast experience, they found that the nephrotic children used to die initially. Why did they die initially and they are not dying now? It was purely because they used to succumb to infections, which is a very serious complication in a nephrotic syndrome. They started using penicillin and many of them survived, but they would still continue to get. And during this period, what was found that there was this new steroid medicine which had just come, and they decided that they found that there must be something wrong immunologically in these children, because why do they get infections? And no sooner the infection subsides, they become alright, few of them. We used to call it a natural remission. So let's do something by which we modulate their immunity. And hence they started steroid. It was just an empiric. Let me be very frank, I had a personal talk with his group, 3 of them. They said this is entirely empirical. But they found that there was a very good result to it. Then they decided, is it that we are only finding this good result, or is it that it is uniformly, globally found in all the other children from different ethnic and different countries? And they formed this group and they had this multi-centric trial. Initially, like everybody else, they did not all agree for the same regime. The people from United Kingdom thought a short courses should be given. They are always cautious because of the side effects. So they used to give only 2 weeks. They used to put the child in a remission. That means the proteinuria would go away. But once they stopped, within a short period of time, they would relapse. So then they decided, okay, 2 weeks is not good enough. Let's give for 4 weeks. And that was more, I think, encouraging, that the relapse rates were not immediate, but after stopping, after a month or so, they would relapse. Then they said, okay, we should not give very large doses, let us go by alternate day. So it was only by trial and error. What I am trying to say, there is no firm scientific basis for what happened almost 50 years back, when this ISKDC was started in, I guess, around 1955 or so. And it went on for about 12 years, 12 to 13 years. But what happened, because of their publications and because they were stalwarts in pediatric nephrology, everybody started using it even before the reports of the trials came, and they found very good results. So it was International Kidney Diseases for Children group. It was labeled as ISKDC regime. 4 weeks daily dose of high dose 2 per kg and 4 weeks alternate day. Now you'll ask me, why did they not extend it to longer period? Because they started getting a lot of side effects. After the ISKDC regime, there was a big gap. Nobody tried anything else, since they found very good results. But as the children were being followed more and more and more, they realized that the relapse rates were very high still. Maybe the relapses did not come immediately, but at least 50% of them were frequent relapses. That means they would relapse more than 2 times in the next 6 months. And then again they had to be given steroids. So a group from Germany decided, why don't we simply compare this ISKDC with a new regime, we call it a German regime, APN for short, and find out whether longer course of steroids is more helpful. And they gave this 6 weeks. It was the same dosage in the same fashion, same selection, but 6 weeks daily and 6 weeks alternating. Now this regime has caught a little bit more popularity because they proved by this trial that the relapse rate could be reduced to 30% from 70%. So this is how I think the studies throw a lot of light in little change from the sort of a duration of the steroids could help a lot of children in not going into relapse stage. So we have come to a crossroad now, because ultimate aim of the treatment of nephrotic syndrome is to induce remission as early as possible. Because if you don't take off proteinuria and the swelling continues to a stage called anasarca, this anasarca is a condition which is very difficult to control, and it is the only reason why few of the children at least die. Because normally the nephrotic syndrome should have a mortality less than 1%. But if you allow the state to continue, then they develop a lot of life-threatening infections. There is a risk of developing thrombosis, blocking of the vessels of the brain, the lungs. There is also a possibility that these children become malnourished because they lose a lot of proteins. There is a growth failure. So considering all these bad effects or side effects of allowing the proteinuria to continue or a nephrotic state, it was found that between the two evils, the steroid therapy is a better evil. So that's how it is by trial and error. And the latest, now we have got all the scientific proof. If you look at the Cochrane data, or if you look at the meta-analysis review of the publications which are on nephrotic syndrome recently, I think there is a more what is called tendency towards treating by this longer regime, that is 6 weeks daily and 6 weeks alternative, to the extent that some of these studies which have been recently published say that why do you stop at 12 weeks? Why don't you give a smaller dose for another 12 weeks? So extending it beyond the ISKDC, I would coin this word, beyond the ISKDC, even beyond the APM, seems to be the current what is called trend. But one does not know. Maybe after a few years, there may be again some change in this regime. But as I said earlier, it is the same drug which is used in a different duration. The initial episode remains the same treatment is started, but how you are going to control the proteinuria and sustain the remission without the steroids is the key issue. There is no answer to that yet. So as we said, we can produce the remission very quickly with the steroids. So the first aim is achieved very easily. But to sustain the remission, we have not been able to achieve. And the most important is to sustain the remission without causing the side effects of the drug is still a far, I think we have not come very close to that.
So what would be your message to doctors who give steroids in tapering doses on their own formulas? Like they may give steroids at 2 per kg, then taper it off and then taper it off on a daily basis, or use different regimes which they are more comfortable with.
Well, I would give a message to the doctors that since we have ample evidence to say steroid does produce remission, one should begin with the ISKDC regime of giving 60 milligram per meter square in 2 or 3 divided doses, or 2 milligram per kilogram per day for the first 4 weeks definitely. It's good to watch the children with weight, high blood pressure or any side effects of the steroids during this period. If there have been no issues and no complications or side effects, one could extend it to 6 weeks. Because if you treat the initial episode very well, there is still a chance that the relapse may be postponed or may not occur. Then comes the period of giving alternative treatment, 1.5 milligram per you can give per kg or 40 milligram per meter square on alternate days. That means you reduce the dose of steroids dramatically, extending to 6 weeks. If you have not found any side effects in the first 6 weeks, obviously you are not going to find. But still the child has to be followed very carefully. You cannot write a prescription and say give for 6 weeks daily, 6 weeks alternate day, send the patient home and tell him to come back after 3 months. The child has to at least seen once a week initially and then once every 2 weeks. Then comes that during these 3 months, if there have been not a single day where the proteinuria has gone beyond trace or nil, that means you have got a very good control of this child. I think extending it beyond this is not a very good idea, because what are you achieving? But you had breakthrough proteinurias. Every child does not have the same type of a response. Then there is a chance, and then again you've been able to control maybe 1 per kg alternate day for another 4 weeks and then 0.5 per kg for another 4 weeks. This is quite empirical, I agree with it, but this seems to be the solution as of today, because there is nothing beyond this. Now I am just talking about the initial episode. Then what does one do? I think you have to make sure that the parents are counseled. I find this lacunae in many of our patients. The patient should know that this is not the end of the treatment. You've got to wait very patiently by doing repeated urine examinations to find whether the child will relapse or not. Now, the definition of relapse, all the doctors know, I'm sure, but the parents don't know. Parents' education plays a very great role. I have found most of even the so-called not so well educated, I wouldn't say uneducated, but if the mother is told to do the urine test and record it in a diary or something and inform or come to us whenever the proteinuria again starts coming into the sort of a urine 2+, 3+, and then she comes to us, rather than wait till the child becomes swollen and has got all the risks of complication. At that stage, at least we could control the proteinuria before the side effects like general anasarcan infections occur. So the patient education during the first 2 or 3 months when the child is going to be brought is most important. But for that, even the doctors need to be educated. How do we tell them? Don't scare them that the nephrotic syndrome is a kidney disease, because the first question is my child going to go into kidney failure? Everybody knows because of the public media and all kidney failure. Not many know that nephrotic syndrome, steroid responsive patient, has very small chance of going into kidney failure, that too over a period of 15 to 20 years. So reassurance, giving them a proper sort of guidance when to detect the relapse, and the relapse needs to be treated with a shorter course of steroids. Because the other thing that the doctor should know, there are any number of alternative medicines which can be tried by the parents if they are not given the proper advice. So one should tell them that this is a relapsing, every relapse is treated with steroids with smaller and dose or a shorter duration. And if the child keeps on responding, there is no risk of, or very small risk, I would put it down, of this child going into a kidney failure requiring whatever renal replacement therapy. And then I think for a pediatrician, it's very important also to take the advantage of this steroid-free period to vaccinate the child, so that they prepare the child in such a way that there are no, at least I would say, preventable infections such as chicken pox or hepatitis B, or for that matter, meningococcal, H influenza, so on and so forth. And this also keeps the child in contact with the pediatrician and knows what is happening. And goes without saying, the diet is important. I'm not going to deal a great deal with the diet, but excess of protein is of no use. But definitely normal protein, and definitely, the hygiene and prevention of infection goes a long way. So what I want to convey to the, the pediatricians and also the parents and the families of nephrotic child is that there is a lots to do, not only during the attack or episode of a nephrotic syndrome, where steroid is the most important, but in between the period of relapses also, to prepare the child in such a way that we minimize the chance of relapse or we minimize the risk of side effects or complications which are the main cause for the morbidity or the ill health of the child, because it's a very, very long course. Anywhere between 5 years to 10 to 15 years one has to wait before the nephrotic syndrome is completely what we would call burns itself out or resolves, or whatever word you may want to talk about.
Lots of children tend to relapse with an infection.
Right.
And once we treat the infection, they automatically go into a remission.
Yes.
Would you consider steroids in such a child?
No. Always right from the initial episode till the relapses, I think it is the main important thing is, first of all, you have to treat the infection, which is usually a trigger to start the initial episode or to begin the relapse. And that infection may be as mild as a viral infection, which does not require a specific treatment. But one has to wait till the infectivity period goes away and then find out whether the proteinuria is still 3+ or 4+ before instituting steroids. And of course, if you find a focus of infection like a throat infection or a urinary tract infection or a gastroenteritis, I think you've got to give enough time for the body's immunity and also the infection to completely subside before we even think of instituting steroids, for 3 reasons. Number 1 is steroids themselves, we know, can aggravate the infection. Also, it is known that while the infection is there, however mild, the steroids will not act. So there is a state of what we call hyporesponsiveness. And the third most important thing, I think, is that during the infectivity period, if you start steroids and the child becomes more serious, you are in a position wherein the steroids have to be stopped. So there is something, though it is not in every patient, what is called a natural remission which can occur by treatment of the infection. So one has to make sure that this point is a very valid point, and this point has to be taken into account for every, right from the initial episode to the relapsing type of a nephrotic syndrome.
Okay. There are times when it's very difficult to explain to parents that with this treatment, I'm going to take care of one swelling, but the child is going to land up with another swelling. So how would you counsel such parents?
Yeah, this is a very, very good issue. When we start the steroids, we are always looking at high blood pressure and this and that, other side effects. But we fail to tell the parents that your child is going to look, the facial features of the child which you are worried about now will change. The swelling of the eyes would come down, but there would be swelling which will be around the cheeks, what is called mooning of the faces. Now, mooning of the faces is a well-known side effects of high-dose steroids, because remember, we are giving very high-dose steroids in a nephrotic child. And if we don't explain to the parents become very unhappy. Because they come after 2 weeks, they say, आपने बोला कि swelling चला जाएगा, अभी देखो कैसा दिख रहा है. So the parents have to be counseled that this swelling of the cheeks which is there is not due to the disease, but it is due to the steroid effect. And no sooner we taper off the steroids and stop the steroids, it will go. And the most convincing way you can say, look, the swelling is there, but look at your urine report. The urine has cleared. So this swelling is not because of the protein in the urine, but this swelling is because of the tablets that you are giving. And this is a known effect, side effect, and it will wane off. So I think, as I explained to you, the counseling is important. But this point has to be told right in the beginning.
Okay, can you give us any clinical markers where we would be able to say this child is going to go into recurrence, or this child is going to be steroid resistant, or this child is never going to have a relapse again?
will not have a relapse is a very difficult situation. Wish we knew that what is that clue, so that we'll be able to take care and prevent relapse. But steroid resistance, yes, we could predict in a small number. Now children whose urine shows a lot of red blood cells, or what we call gross hematuria, that means red urine, which is very, very rare in a child who will respond to the steroids. That surely, or child who has got a high blood pressure before starting steroids. That is a second indicator, so to say most probably this is not the usual case of a steroid responsive. Children who have an attack of the first episode of nephrotic syndrome, less than 1 year of age, or many of them after 12 years of age, so much beyond the normal age where they are expected to have, would be steroid resistant. So much so that children with the onset below 1 year, sometimes we said we don't recommend steroids because they are not going to respond to steroids. Then we do certain tests, blood tests, to confirm the diagnosis of nephrotic syndrome, like serum albumin, cholesterol, then serum proteins. And then if we find that the BUN creatinine, which is an indicator of a kidney functions, if you find that there is a high BUN creatinine right in the beginning, not a transient but persistent, that means there is some primary disease already existing which has caused a kidney failure, at least the beginning of the kidney failure. Now such children also would not. Then there are some adolescent girls who have nephrotic syndrome. Now they have rash on their cheeks or rash on the legs, or they have some joint pains. That means they have symptoms of diseases beyond kidney. Something to do like what we call rheumatological signs. Now such children also initially may respond, but in the long run will not be I would say will get over the nephrotic syndrome. So we have a checklist of all the symptoms and signs which accompany the nephrotic syndrome, and we make use of this right in the beginning to at least have some idea about the steroid responsiveness or resistance. But ultimately we do give steroid for at least 4 weeks before we say the child is steroid resistant. And the further treatment entirely depends then on the kidney biopsy.
Can you tell us about some newer molecules like mycophenolate and tacrolimus, and even a newer steroid that has come into the market, that is deflazacort? Can you tell us about that?
See, there are many new molecules which are used and which have been tried. Some of them have been tried without a proper randomized double-blind studies to find out whether they are efficacious and whether they can be used clinically. But there have been studies to say deflazacort. Let's take steroid molecule. Deflazacort is a little bit different molecule than steroid, but the basic effects of deflazacort are similar. There are many advantages of deflazacort if we want to use it for a very long period. For example, we know that these glucocorticoids, that is prednisolone, is known to cause sodium and water retention and hypertension. It is known to cause bone demineralization. That means if you are going to give for a longer period than 3 months, then it will definitely cause some sort of vitamin D and calcium deficiency, or it will also cause pain, bone pains. It is also known to cause myopathy, and it is also in the long run can cause growth failure. But all these things which happen by use of prednisolone are if you exceed the duration beyond 6 months. Now if you need to give steroids to a patient beyond that, then deflazacort is a good molecule because it has got less side effects on this hypertension, bone demineralization as well as growth failure. At the same time, because it is a weak molecule, it does not induce remission very quickly. So it's not a good idea to start with deflazacort. But it may be a good idea to replace prednisolone after having achieved what is called a remission, if you are intending to use it for a very long time. Now these situations arise if the patient is either steroid dependent or frequent relapser, because then you are more worried about the steroid side effects. So you can use deflozacort. In our country, it has been recently been introduced. It's quite expensive, number one. And number two, there are not enough trials in our country to say that it can totally replace prednisolone. But it is a good drug to try, and if the patient can afford, why not? Because the side effects are reduced. As regards the tacrolimus and cyclosporine, these are the so-called calcineurin inhibitors. Now, as I talked to you earlier, that though we don't know the cause of nephrotic syndrome, there are many evidences to say that there are some immunological mechanisms which are involved, especially because there is a propensity to infection. And the focus is not only on the loss of immunoglobulins, which causes immune deficiency, which is very easy to explain. I mean, immunoglobulin is a protein, so a lot of it is lost. So the blood levels are low, and that is why you can get a bacterial infection. But there is not enough evidence to say why do they get infections wherein the immunoglobulins are not important, such as say tuberculosis or fungal infections, which are very severe. So the reason is they have what is called T cell dysfunction or a cell mediated immunity. Now, looking at the drugs which are known to alter this cell mediated immunity, it has been found from the experience on the transplant immunology that there are immunosuppression or immunomodulators such as calcineurin inhibitors, which are the IL-2, interleukin-2 inhibitors, which are known to suppress the immunity to such an extent that the donor's kidney is not rejected. So on that basis, some of the trials have gone on in those patients who did not respond too well to steroids, kept on, having frequent relapses or steroid dependency, and those who did not respond to steroids on these, but these numbers are very small. They are not double-blind randomized controlled trials, and tacrolimus is one of them. It used to be called F508. It was not even, the name was not given, and these were tried in selected patients with good results. Now, good results means what? If you take 10 patients, because steroid resistance itself is not such a common disease, so you won't get large numbers by one center, maybe 3 will respond, so one would put it down 30%. But if you look at the steroids also, 30% will respond initially. So it was not a dramatic, but at least we had something to go by, and probably the toxicity profile was much less when given for a long period of time. Steroids caused a lot of side effects, and it was very obvious, like hirsutism and mooning of faces. Well, tacrolimus and cyclosporine, for that matter, do not cause so many side effects immediately, but long term they are equally having bad effects such as nephrotoxicity. So tacrolimus is one. We are not used too much of tacrolimus. We use a lot of cyclosporine in steroid dependent frequent relapses and few cases of steroid resistance. But to sum up my own experience and also worldwide, they have not shown such a good result so as to recommend in every patient. But we would definitely recommend them in adolescent girls and boys, because during this active spurt of growth, the steroids definitely is responsible for stunting or short stature. Steroid also is a very unpopular drug with the adolescents because they look very odd and they don't like to look, the way there is a lot of psychological bad effect, poor self-esteem, and they don't socialize because they look odd. All those effects are not found with the cyclosporine or tacrolimus. So I always say that if a child continues to require steroids beyond 12, 13, 14 years, we can replace it with cyclosporine. Give for 2-3 years to make sure that all these facial changes and the growth, retardation, etc. will be taken care of. At the end of it, again, if they relapse, you go back on steroids. So it is what is called steroid sparing agent. So there are a number of these steroid sparing agents. I talked of only 2 of them. But MMF or mycophenolate mofetil is one of them, and the action is like azathioprine. It acts selectively on the purine synthesis. Again, it is a immunomodulator or a immunologically it alters the response of the T cell function. It is recommended definitely and found to be very good in selected cases of systemic lupus erythematosus, but not idiopathic nephrotic syndrome. Our experience is small. There are a number of articles one finds in the latest publications of pediatric nephrology, and some of them say that it is worth trying as a last resort. When you say last resort means nothing has acted, or things have acted but have given rise to a lot of side effects, and hence one can use. Compared to cyclosporine and tacrolimus, it is a less toxic, because in the long run, cyclosporine and tacrolimus themselves are nephrotoxic drugs, and they can cause again renal injury which is irreversible. MMF comparatively no side effects on kidneys, but has got some side effects. You got to pay for something when you use it. So one can say that it has got suppression of the bone marrow, so it has got hematopoietic side effect, and it is also known to cause liver injury. So with this knowledge that there are side effects which are quite significant, but still one can give a trial for 3 months. Again, the cost is a major factor. MMF being the last entrant is more expensive than cyclosporine and tacrolimus, but they are all expensive, and the patients have to pay monthly maybe almost 10 to 12,000 rupees, and minimum period of 3 to 6 months or even longer. So if a fording patient wants to try it, nothing like it. But I would put it down, this is not in the domain of a general pediatrician. Right. I think once that stage comes that the steroids are giving a lot of side effects and there is a need for the so-called steroid sparing agent except Levamisole, then I think it is better to work with the pediatric nephrologist rather than start using these drugs on your own.
Right. That comes to my last question, and the question is on your phenomenal paper on Levamisole and your phenomenal studies and outcome of Levamisole in children. So can you share that experience with us?
Yeah, I mean it was a very satisfying experience to us when way back in 1980s when we started studying nephrotic syndrome, the immunological studies in the nephrotic syndrome. I'm not claiming that we were the first one, because I think it's this thing to say. I would be arrogant in saying that. I'm sure similar studies were being carried out in the rest of the world. But what was struck to us that we were probably hitting at a target issue, and that issue was, as I said, that there was a T cell dysfunction in every single child with nephrotic syndrome, even without infection. And then we said, isn't it illogical to treat a child who is immunodeficient with an immunosuppressant? Because as we can categorize, you find steroids, then also cyclophosphamide, which was very popular, chlorambucil. These are immunosuppressants. So we are using an immunosuppressant medicine in a patient who is already immunocompromised. So is there the other side of the coin? So we started searching for immunostimulant. Let's use something, or think of using something which will stimulate the immunity. Maybe it will not cure the child of the nephrotic syndrome, but at least the recurrent infections would be, not a major problem. So to our great surprise, when we looked at it, we found Levamisole, which is an anti-worm treatment in fact. We were using Levamisole for roundworm infections and all, and piperazine citrate, which was being replaced by other medicines. Albendazole had not yet come. So when we got pretty excited, and then we said, let's make a sort of a small trial. It was not a double-blind trial, to be very. And the first 30 patients of nephrotic syndrome. Prospectively, we used Levamisole. We got one single article to go by because we needed something to go by from Thailand and Pediatric, I still remember, who had treated 4 or 5 patients of nephrotic syndrome with good results. So on the dosage etc. were taken from them, and we found that it is a drug which did not cause any side effects. And we found in those who were relapsing, we had partial remission. I've got that paper, almost in more than 50%, and complete remission in 50% of those who earlier on were relapsing almost every month or every 2 months. So one would put that historically the patients themselves became their controls. They had a lot of relapses, and then we extended the treatment from 3 months to 6 months, and we gradually increased the duration of the Levamisole, which was given initially 2.5 milligram per kilogram alternate day, to even 18 months. And during that interim period, we found that we had very good results, and they were not small number, 30. Now when we presented in the abstract form in number of the international meetings, people were amazed. First of all, they couldn't believe. Secondly, when they found out that it was a very well designed study, that we had studied immunological, we had proved that there was a T cell dysfunction, and we had used the immunostimulant, which was logically, the way all scientific people would do that, and the results were there. So it was in Japan in 89 that I was given the opportunity of presenting to the whole pediatric nephrology community. It was one of the most important paper. I was given the main auditorium and all, and when I talked about it, people were quite convinced, and they started this trial. In Britain, the UK people are the most critical for everything, and it's good, and they started the UK trial of the Levamisole, and they found similar results. Then French people started. It was Canada, it was allowed to be used. It's only US FDA did not clear the drug for the common use in nephrotic syndrome. But all these studies came to the same conclusion. So without even designing a trial, it was like a multi-centric trial. And all of them found the similar results, provided you used it in frequent relapses and steroid dependent. We could even withdraw steroids from all these patients, and they continued to be in remission. So it was very well accepted by the Archives of Disease of Childhood, and I think it is quoted all over wherever Levamisole is, sort of mentioned in textbooks and all. And we were fortunate that I would put it down, it was not by fluke, but it was by the going into the depth of the, trying to find out why there is an immune deficiency. And then I think now it has been accepted as a part of the protocol. So I wish I was young enough to get some more ideas at this stage, because I feel very unhappy for those small number of children who somehow or the other fail to respond to anything that we give them. And they are the ones which are real challenges to us.
Thank you very much, Dr. Kumud Mehta, and we will be back again with another small topic with her. And thank you very much.
Thank you.